And without further ado, Research to Practice, Obesity and Cancer Prevention, the Efficacy and Timing of Bariatric Surgery with Maggie M. Hodges, MD, MPH. All right, Dr. Hodges, welcome. So glad to have you here today.
Thank you very much for having me. I'm excited to be here.
Absolutely. So we're not going to read all of that, but rather we'll go ahead and try to get to the top points here. So Assistant Professor of Surgery at the Department of Surgery at the University of North Carolina, Chapel Hill, and serves as Associate Program Director for the Advanced Gastrointestinal and Minimally Invasive Surgery Fellowship Program. Clinical practice is focused on de novo and reoperative bariatric and foregut surgery. Her postdoctoral research focused on in vitro and vivo evaluations of cellular mechanisms underlying diabetic wound healing impairment, as well as novel mechanisms of myocardial regeneration and myocardial infraction. And finally, currently serves as a site PI for PCORNet. And excuse me, I've got something that is getting in the way on my screen. There we go. Investigation, evaluation, and impact of bariatric surgery on cancer detection and outcomes. Dr. Hodges, welcome again. What's one thing we should know about you outside of your very impressive professional bio there?
In addition to the people that make this possible, I have a 7-year-old daughter at home and a almost 5-year-old son, and we've taken on a new adventure of trying to keep a small selection of plants alive until the rains allow us to plant them outside in the yard.
Oh, good for you. Good for you. I can understand that our bathtub is currently full of plants.
We're trying to keep away from the cats away from the plants is the next challenge.
That's a big one with serious consequences. So yeah. Let's see. We mentioned poll everywhere. So we'll ask our audience to go ahead and again pollev.com, put in the letters UNCLCN, all anonymous. Our first question is: I understand indications for bariatric surgery. That'll be true or false. While you're doing that, I'm going to flash up our ACCME disclosure and our ANCC disclosure. And now let's take a look. And so we'll give everyone about 10-15 seconds to respond. And of course, there's no right or wrong answer on this, but this is very helpful to Dr. Hodges and seeing where you as an audience member, where your background lies. All right, Dr. Hodges, it looks like we've got about 38% that say yes, they understand the indications, and about 65 that say no, they don't. So
excellent.
Good place to start.
I look forward to helping with all that today.
That sounds great. And without further ado, obesity and cancer prevention, the efficacy and timing of bariatric surgery. Dr. Hodges, you should have a control on the bottom of your screen towards the left, and I'll turn it over to you.
Okay, thank you so much. So good afternoon, everyone. I'd like to thank Lineberger for the opportunity to present today, as well as John, Tim, and Lindsay for your patience coordinating with my schedule and my limited tech knowledge and probably my poor communication skills on top of all that. I do have some relevant disclosures to talk about. As John mentioned, I am a site co-PI for a PCORNet funded investigation looking at the impact of surgery on cancer or bariatric surgery on cancer diagnoses. This is in the very early stages, and I'll not be discussing those results today. Otherwise, my only relevant disclosures are that I am a bariatric surgeon and I think cancer is bad. The objectives today, during the presentation, I'm hoping I can provide kind of a surgeon's mile-high view on pathways through which obesity and bariatric surgery may influence cancer development and cancer progression, as well as the current knowledge base regarding the impact that bariatric surgery has on cancer and cancer outcomes, so that we can all hope to better understand the optimal timing of bariatric surgery as it relates to cancer treatments. So if y'all could go in kind of the next question, I'm curious to know what your opinion or thoughts on what the answer might be is what proportion of cancers do you feel or is your impression are considered obesity related? give you another minute or so. I'll try and keep my face blank so nobody changes their answers based on my response. Okay. Okay, great. Last one grade. Okay, good. I think we'll kind of let it settle out right around there. Okay, you won't get the answers yet, but I promise you will shortly. And then just out of curiosity, I know we have folks coming from a variety of practice patterns and practice positions, but have you ever referred someone to bariatric surgery or been in a position as a healthcare provider kind of at any level counseling someone on the indications for or need for bariatric surgery? Okay. Timing there, I apologize. Okay, perfect. We will let that move on. I apologize. Not sure how to put that on hold. Okay, moving on there. And then last question, kind of before we launch into the information is what proportion of patients who you think qualify for bariatric surgery, whether or not you know the indications, actually go on to receive it? Okay, sorry for that, guys. Okay. Okay, good to know. Okay. Well, launching in a little bit, we'll start with some of the epidemiology of obesity. It's something that has been more and more in the news lately, so some of this might not be new information for you, but it may be surprising for many folks to know that obesity was actually not initially recognized as a disease by the American Medical Association until 2013. By that time, of course, the pandemic of obesity had already reached such proportions that it was actually felt by folks in the AMA that it was necessary to officially define it in order to increase kind of attention to the need for research, funding, and awareness of obesity as a disease from a public health standpoint. The global prevalence of obesity has risen from less than 1% in 1975 to greater than 40% in 2020. And conservative estimates are placing kind of all-comers folks who qualify with a diagnosis of obesity, which is anything with a BMI over 30, at greater than 1 million people across the globe. During that same time frame, rates of obesity have quadrupled in adolescents, have tripled in men, and have doubled in women. The US remains a clear global leader in the obesity pandemic, where the overall prevalence of obesity was 41.9% in 2017. The lowest prevalence was observed in non-Hispanic Asian adults, but this number can often be misleading. Again, most folks define, or the standard definition of obesity is a BMI greater than 30. However, when you want to talk about the impact that excess weight has on a population, in particular, non-Hispanic Asian adults have been observed to be at a higher risk of those metabolic impacts that we associate with obesity, but at BMIs that are traditionally in the overweight range, so more in the kind of 25 to 29 range. So there are nuances that we're still kind of defining, I think, as a field in terms of identifying those who are at risk of obesity-related comorbidities. And BMI is not a perfect number, and so we're still kind of working on those metrics. The highest prevalence of obesity in the US was observed in non-Hispanic Black adults, Hispanic adults, and non-Hispanic American Indian or Alaskan Native populations, with non-Hispanic Black adults having over 49.9% of their population defined as obese. The national depictions of the distribution, as you can see, and particularly relating to the non-Hispanic Black adult population, shows the disease burden consistently identifying a disproportionate burden of obesity in the southern United States. Obesity is associated with over $172 billion in direct medical expenditures in 2016, as well as both as increased outpatient, inpatient, and prescription medication costs. And then the health impacts of obesity are many and varied. They affect every organ system, either directly or indirectly, including increased risk of stroke, coronary artery disease, sleep apnea, obesity hypoventilation syndrome, reflux disease, non-alcoholic fatty liver disease, intertriginous skin rashes, type 2 diabetes, renal failure, infertility, osteopenia and osteoporosis, as well as sarcopenia, so loss of muscle mass as well. And then, of course, the reason we're all here today, cancer. The CDC in 2017 estimated that 40% of all cancers diagnosed in 2014 were considered obesity related. So there's that answer to that kind of first question. 40% of all cancers are considered obesity related. 55% of all cancers diagnosed in women are considered obesity related. And 24% of all cancers diagnosed in men are considered obesity related. And the increase in annual cancer incidence can be seen to correspond nicely, unfortunately, to where we also see the highest prevalence of obesity in the United States. The types of cancer associated with obesity are also widely varying and include meningioma, thyroid cancer, multiple myeloma, colorectal cancer, and esophageal cancer, in addition to the more historically known obesity-related cancers like breast, ovarian, and endometrial cancer. While the risk ratio of endometrial cancer conferred by obesity is 1.59%, so something blocking my screen there, as you can kind of see down here, I do want to draw attention to the fact that if you look at esophageal cancer, there's a very similar relative risk of esophageal cancer associated with obesity. And so I think we need to start expanding our historically identified obesity-related cancers and recognize that there are other mechanisms at play besides obesity-related estrogen exposure, which is what we've typically identified as being root causes associated with breast, ovarian, and endometrial cancer. Now, with that being said, estrogen does play a role. Adipose tissue is high in the aromatase enzyme, which increases the conversion of circulated androgens to estrogens. And high levels of estrogens have been shown to increase the risk of developing those breast, endometrial, and ovarian cancers, but also colorectal and prostate cancers. Some studies also show an increased risk of hepatocellular carcinoma in the liver, but there are also reparative and maintenance pathways that are driven by estrogen, and so that literature seems mixed. The caveat to that statement being I'm neither a hepatologist nor a hepatobiliary surgeon who may have a better understanding of that literature. But there are also multiple other pathways at play, again, outside of this estrogen pathway. These are increasingly being identified as driving obesity-related cancers, both development and progression. Adipose tissue is composed of both adipocytes, so the little kind of fat globules here, but as well as the stromal cell population, so these kind of supportive cell population. That supportive cell population is composed of macrophages, endothelial cells, other inflammatory cells. And when compared to non-obese counterparts, patients with obesity demonstrate an associated increase in both the adipocyte, the actual fat cells, as well as the stromal cell populations, more so relative to their non-obese counterparts. The increase in the stromal cell population leads to an increase in excretion of leptin and pro-inflammatory cytokines like interleukin-6, as well as tumor necrosis factor, and a reduced expression of adiponectin, which becomes important here shortly. With increased leptin expression by the adipocytes, there's an increased activation of these JAK-STAT-dependent signaling pathways that lead to an increase in anti-apoptotic transcription factors such as BCL2, as well as increased pro-metastasis pathways like the matrix metalloproteinases and cell adhesion molecules. Leptin's also been known to increase expression of estrogen receptors in colon, prostate, and breast tumor cells. And co-culture of colon tumor cells with adipocytes actually increased proliferation of those colon cancer cells when they came from a wild-type mouse, but not when the adipocyte came from a leptin-deficient mouse, suggesting that leptin production is critical to that relationship. Epidemiological models kind of correlating circulating leptin levels with cancer incidence have had mixed results, but they've been performed across a variety of cancer subtypes and populations, so it's made those results a little challenging regarding generalizability. Another adaptomite that plays a role in cancer development is adiponectin, and lower levels of adiponectin are generally associated with obesity. So in non-obese individuals, usually there's a higher ratio of adiponectin to leptin, whereas in obese individuals, you see more leptin compared to adiponectin. Lower levels of adiponectin, as seen in patients with obesity, are associated with an increased risk of postmenopausal breast cancer, endometrial cancer, and prostate cancer, as well as renal cell carcinoma and colorectal cancer, with increased levels associated with increased cell death and hepatocellular carcinoma. Similar to their roles in maintaining obesity or adiposity, both in vitro and in vivo models, adiponectin and leptin seem to have opposing roles. Tumor-bearing mice that are treated with leptin demonstrate an increase in the growth of those tumors, and that growth is impaired when you treat that population of mice with adiponectin. Now, the other thing that obesity leads to is development of adipocyte precursors, and this is kind of a vicious cycle. This is the obesity getting more obesity. Adipocyte precursors demonstrate an increase in that stromal fraction that produces all those pro-inflammatory cells and interleukins that we discussed previously. They also secrete pro-angiogenic factors that increase blood vessel formation, as well as chemokines and growth factors that have been observed to increase tumor metastasis and tumor growth in animal models. And in addition to those pathways, obesity leads to increased risk of cancer due to an increase in systemic inflammation, insulin resistance, hyperlipidemia, as well as impaired health system utilization. Cytokine production by the adipocyte population increases activation of macrophages to a pro-inflammatory state, increases macrophage infiltration, and macrophage proliferation and infiltration in tumor cells has been associated with worse prognosis long term. Obesity has also been associated with accelerated telomere shortening. Type 2 diabetes has long been known to be associated with obesity, and as well as being associated with a significantly pronounced increased cancer risk up to 200%. And that's independent of the risk of obesity. A diagnosis of type 2 diabetes predicts a more aggressive cancer phenotype for many cancer types. And higher levels of circulating insulin-like growth factor and insulin IGF binding proteins, which we see in type 2 diabetes, are also associated with an increased risk of prostate and breast cancer. Hyperlipidemia and hypertriglyceridemia are also increased in obesity, and lipid metabolism generates a variety of bioactive lipid molecules that can activate macrophages to pro-inflammatory phenotype. And increased lipid metabolism has also been noted to be a key metabolism or type of metabolism in cancer metabolism. And finally, health system utilization is often increased among patients with obesity. Not only is there a strong directional relationship between obesity and mood disorders that may lead to patients delayed seeking care and kind of routine health maintenance, but 68% of patients with obesity report delaying seeking care because of the stigma associated with their obesity. And 83% of patients with obesity report that their weight gain has limited their ability to receive appropriate health care, either due to explicit or perceived healthcare worker bias. So not only is this a vulnerable patient population biologically, but it's a vulnerable patient population socially as well. Now, let's talk about bariatric surgery and how that plays a role. We see some of that possible healthcare worker bias in small volume of eligible patients who go on to receive bariatric surgery, although there are additional risk factors at play, including access to care and health insurance coverage variability, social stigma, adverse surgical histories from early on in the history of bariatric surgery, as well as compliance with the bariatric surgery process. So despite the fact that 0.9% of the US population qualifies as obese, less than 1% of patients who are eligible for bariatric surgery go on to receive it. we keep it in the context of 41.9% of the US population being obese, only 0.05% of the US population actually undergoes bariatric surgery each year. Bariatric surgery trends have very widely in the last 20 to 30 years. It was initially dominated by gastric bypass up here with the advent of minimally invasive surgical techniques. Gastric bypass kind of the adjustable gastric band had a brief period of dominance here in this little hill here before longer term outcomes recognized that that the longer term outcomes were poor with the high rates of requiring removal as well as weight regain and further complications. And more recently, in the last 10 years, the lap sleeve gastrectomy has kind of taken over. So the two most common surgeries we do today are the lap sleeve gastrectomy, which is depicted up here on the top, followed by the gastric bypass. The sleeve gastrectomy is generally considered mostly a restrictive procedure where 80% of the stomach is permanently removed and relies mostly on the restriction provided by that decreased gastric volume. There are some other additional hormonal and kind of effects as well, but those tend to level out after about 6 months. And the laparoscopic gastric bypass is both restrictive in that there's a gastric that we bypass, as the name implies, a certain amount of intestine. All otherwise stay in place, but the anatomy is rerouted. More recently, there's interest in slightly different malabsorptive procedures like the pancreatic diversion and duodenal switch here, where it's kind of a combination of the two. There's a slightly larger kind of sleeve component here. And instead of having this is a gastrointestinal, so an anastomosis between the stomach and the small intestine, this becomes anastomosis between the duodenum, which is the first part of the small intestine, and the ileum, which is the distal small intestine, and is a more pronounced malabsorptive procedure. However, despite kind of increased excitement about that procedure, that still only represents about 1.5% to 2% of all bariatric surgery procedures performed each year. And then over the last 20 years, we've had the opportunity to better understand the long-term effects of most of these surgeries as well. And we know not only are those surgeries generally very safe, but the weight loss is generally well sustained. There may be some small weight regain from kind of the initial nadir that all patients experience around the kind of 1 year, 18-month mark. But generally speaking, and this is kind of beyond 5 years in this graph here, significant weight regain isn't observed. And when it is observed, it's observed in far less than 10% of patients. And then we also know that the effects of bariatric surgery are far-reaching and not simply about the weight loss. It's a hard sell for folks to undergo the risks of a surgery for something that might seem purely a cosmetic benefit, and that's certainly not why it's recommended. It's the additional lifestyle benefits and metabolic benefits that we'll discuss here. So bariatric surgery has been shown to be incredibly effective in inducing the remission of type 2 diabetes, with over anywhere from 40 to 90% of patients experiencing complete remission of their diabetes greater than 3 years after surgery. And even patients receiving, and even further patients receiving the added benefit of reduced use of anti-diabetic medication. In addition to diabetes, we see significant improvements in management of high blood pressure. When compared to standard medical therapy, bariatric surgery has been shown to be incredibly effective. Looking specifically at patients who are requiring 2 or more antihypertensive medications prior to surgery, gastric bypass was associated with 47% of patients requiring no antihypertensive therapy 5 years after surgery, and overall an additional 30% reduction in the amount of overall antihypertensive medications used in the surgical cohort. This is compared to kind of a small 2.4% likelihood of being off of all antihypertensive medications 5 years after at the 5-year follow-up mark in patients who did not receive surgery. As it pertains to both ischemic heart disease and heart failure, bariatric surgery has also been associated with a 44% reduction in composite adverse cardiac outcomes in patients with ischemic heart disease 8 years after surgery, and a 58% reduction in composite adverse cardiac outcomes in patients with heart failure 8 years after surgery. These are not contraindications to undergoing bariatric surgery. And then finally, as a surgeon, I never thought that sleep apnea would become the topic of my kind of clinical soapbox. But I find that more and more patients in both my bariatric practice as well as my foregut practice don't truly understand the impact that untreated sleep apnea can have on them, both before and after surgery. But gastric bypass was able to actually cure sleep apnea in 2/3 of patients 3 years after surgery, compared to usual therapy, which actually saw an increase in the proportion of the population with mild and moderate sleep apnea. So can't kind of underscore that effect enough. But as much as I'm sure y'all love to hear about those effects, what you're here today is to help understand is how does bariatric surgery influence cancer risks? And so before I move on, let's revisit some of the questions I asked you at the beginning and make sure everybody's coffee is kicking in and we're still listening. So revisiting that, one of those first questions. Let's see, what proportion of patients qualify for bariatric surgery go on to receive it? Who remembers that answer? You're awake, you're listening. Thank you. Love it. And then again, what proportion of cancers are considered obesity related? Outstanding. Okay. So let's talk about that. So what can bariatric surgery do to help reduce that risk, that 40% risk of obesity-related cancers? So to jump to the punchline just a little bit, looking at the risk of developing an obesity-associated cancer following bariatric surgery, we see a 25% reduction in overall cancer incidence, a 37% reduction in obesity-related cancer incidence, and a 43% reduction in cancer-related mortality. And we also see a nice graded response dependent on the degree of weight loss that patients experienced following their bariatric surgery, with the lowest cancer risks being associated with the highest percent total body weight loss, and the highest cancer risk being associated with the total body, the lowest total body weight loss. So kind of an inverse relationship there. And while some cancers have yet to be well studied in the pre or post bariatric surgery population, in those that have been looked at, we do see similar effects across the gamut of cancer types. With regard to breast cancer risk, the 5-year risk of developing breast cancer was reduced from 1.6% to 1.3% after sleeve gastrectomy, with even further following up demonstrating that this risk reduction is observed in both premenopausal and postmenopausal breast cancer. A meta-analysis looking at 11 papers that included over 11 million patients demonstrated a 50% reduction in breast cancer diagnosis following bariatric surgery, with a decreased risk of higher stage disease. So more likely to have stage 1 and stage 2 disease breast cancer at the time of diagnosis compared to stage 3 and stage 4 disease diagnosis in patients who did not BMI matched controls who did not undergo bariatric surgery. Similarly, in endometrial cancer risk, sleeve gastrectomy was able to reduce the risk of endometrial cancer from 0.86% to 0.56% 5 years following surgery. And when we looked at patients as far as 38 years following sleeve gastrectomy, that risk was reduced from 1.3% to 0.3%. A meta-analysis of 7 studies estimated there was a 67% risk reduction in endometrial cancer risk after bariatric surgery. And then ovarian cancer risk, again, similarly reduced. 5-year risk reduction from a rate of 0.43% to 0.15%, and overall a 53% reduction in ovarian cancer risk after bariatric surgery. Thyroid cancer risk, again, not one of these that's not necessarily notoriously considered an obesity-related cancer. However, 5 years after bariatric surgery, the risk of a thyroid cancer diagnosis was reduced from 0.43% to 0.15%, and overall considered a 53% reduction in the risk of being diagnosed with thyroid cancer. Similarly, as we already touched on, esophageal cancer risks. Sorry. It has been a little tough to tease apart the impact of bariatric surgery on esophageal cancer risk because of the proximity of the cancer to the surgical site for most bariatric surgeries. But the most recent and largest studies that have been better controlled for changing rates of bariatric surgery over the years demonstrated a reduction in the risk of esophageal cancer diagnosis from 0.04 to 0.03% at 38 years follow-up. And across the board, there was a 30% reduction in the diagnosis of an esophagogastric cancer, even as short as 6 years following bariatric surgery. Colorectal cancer risk is also reduced following bariatric surgery, with a 36% risk reduction 7 years after follow-up. And then again, while the precise kind of mechanisms and the impact of estrogen on hepatocellular carcinoma risk is still perhaps a little foggy, the epidemiologic data would suggest that bariatric surgery continues to be associated with a reduced risk of hepatocellular carcinoma, with an odds ratio of 0.11, as well as a reduced risk of in-hospital mortality associated with hepatocellular carcinoma, with an odds ratio of 0.22. There's also a reduced risk of NASH, which might be related to the reduced hepatocellular carcinoma risk following bariatric surgery. And then as it pertains to renal cell carcinoma, we know that renal cell carcinoma risk is reduced from 0.31% to 0.21% after gastric bypass, with a 38% risk reduction 38 years following gastric bypass. And as it pertains to pancreatic cancer has been associated with a 24% risk reduction in pancreatic cancer risk, anywhere with a 5-year risk reduced from 0.09% to 0.05% 5 years following bariatric surgery diagnosis. In addition to these bariatric surgery rates and kind of incidences of cancer, we also know that bariatric surgery and obesity have impacts on outcomes following cancer treatment. In particular, we know that obesity is associated with an increased risk of lymphedema in patients with breast cancer, with higher BMIs associated with higher rates of lymphedema. We also know that increased rates of the use of taxane and platinum-based chemotherapies are associated with an increased risk of peripheral neuropathy in patients with obesity, and that anthracycline and trastuzumab-based chemotherapies are associated with an increased risk of cardiotoxicity in obese patients. There's also an increased risk of radiation-associated dermatitis in high BMI patients, and across the board, an increased risk of postoperative complications. As a result of this, and in addition to this, obesity has been shown to impact decisions regarding immediate breast reconstruction following mastectomy in obese populations. Whether chemotherapeutic doses are capped at doses short of the recommended weight-based therapies because of the required the need to weight-based doses in obese populations. And from a surgical standpoint, we know that obesity can impact decisions regarding open versus minimally invasive techniques for intra-abdominal cancers. An open versus an minimally invasive technique for patients with intra-abdominal cancers can cause significant differences in morbidity as it pertains to wound infections, occurrences of incisional hernias following open surgeries, as well as prolonged length of stay in patients requiring an open operation compared to a minimally invasive operation. So these are not small decisions to make in patients who are already, again, disproportionately affected by their disease process. So when should bariatric surgery be considered? Well, I think we would all agree that ideally, in order for bariatric surgery to be involved, this should take place as a preventative measure before a cancer diagnosis is even identified or suspected. And the ASMBS, which is the American Society for Metabolic and Bariatric Surgery, which is kind of the overarching body for bariatric surgeons and obesity medicine physicians, has actually recently expanded their criteria to include anyone with a BMI over 30 and poorly controlled diabetes. Unfortunately, a lot of the payers haven't formally recognized this, and so that's still something that's actively being advocated for. But across the board for many years, the criteria for bariatric surgery includes a BMI over 35, in addition to any obesity-related comorbidity, including type 2 diabetes, hyperlipidemia, reflux, sleep apnea, coronary artery disease, non-alcoholic fatty liver disease, as well as osteoarthritis, and anyone with a BMI over 40, independent of other metabolic comorbidities or comorbidities across the board, qualifies for bariatric surgery evaluation. Now, do we need to expand some of these relative to the recent and kind of knowledge we've discussed here today, looking at the impact of cancer on obesity? Should we consider patients who have a BMI over 30 with a family history of obesity-related cancer or personal history of obesity-related cancer? Or should we consider patients who have a BMI over 35 after menopause at a higher risk of some of these cancers? Some of this information has yet to be decided, but it's important, again, to look back and understand that almost in a pseudo-dose dependent response, that the impact of bariatric surgery significantly reduces the risk of developing a cancer following bariatric surgery. Again, as evidenced by this graph, clearly depicting the patients who have the most successful weight loss outcome following bariatric surgery go on to have the lowest reduction in risk of developing cancer down the line. Now, when should bariatric surgery be considered? Oof. When should bariatric surgery be considered during cancer treatment? Now, this can, be controversial, particularly because not all cancer treatments and cancer pathologies and phenotypes are considered the same. However, patients with endometrial cancer in particular, who are young and perhaps desire uterine preservation, have been shown to demonstrate complete resolution and regression of their endometrial cancer following bariatric surgery and hormone therapy. These are relatively new in the last couple of year concepts that are increasingly being worked upon. And while typical kind of algorithms as depicted here that look to modify estrogen drivers of angiogenesis and immune responses to cancer, all can show kind of beneficial responses in the bariatric surgery process as well. Similarly, deferring oncologic surgery for some of these patients has been proposed until bariatric surgery can facilitate weight loss that might optimize their use of a minimally invasive technique. Again, most often this has been proposed in somewhat indolent cancers, endometrial cancer being one of them. There are some colleagues out of Cleveland who are also considering use of kind of very slow-growing indolent renal cell carcinoma in obese populations in order to salvage kidney for isolated ablation and or resection of slow-growing renal cell carcinomas that would not otherwise be feasible in an obese population. And so targeting those patients to optimize them from a weight loss perspective using bariatric surgery, in addition to optimizing their long-term cancer outcomes. And what about during cancer treatment? This is again kind of throwing out some of the questions and concerns that people are considering these days. And unfortunately, there's not a simple kind of carte blanche answer to any of it. Can it be used as an adjuvant therapy after chemotherapy has been surgery perhaps has already been accomplished? If chemotherapies wouldn't adversely impact the surgical outcomes following a bariatric procedure, I think adjuvant therapy would not be unreasonable. Similarly, as neoadjuvant therapy, I think only in very unique situations where the cancer is very slow growing and indolent, and perhaps where there may be hormonal therapy or immunotherapy that wouldn't otherwise, again, place a patient at risk of adverse outcome following a course of chemotherapy or radiation therapy. And then as a simultaneous surgical intervention, there are not unheard of situations where that might be the case for some patients. However, it is important that when surgical intervention is proposed for a cancer surgery, that they also need to be able to recover safely following that cancer surgery. And that usually requires optimization of nutrition, vitamins, and nutrients in order to be successful following their surgical resection. And so, again, some of this is very much a gray area that I wish I could shine a guiding light on. And I very much look forward to clarifying over the next 5 to 10 years, because I think this is a very exciting time to help define some of these indications. Sorry. Okay. And then after a cancer diagnosis, when should bariatric surgery be considered? I think it is very reasonable to consider including bariatric surgery in a survivorship process for any cancer survivors. If patient has weight regain after a diagnosis of cancer, which is not uncommon given the medications, as well as often kind of stressors and lifestyle situations associated following a cancer diagnosis. It should certainly be considered as a discussion for as an option for the patients. Obesity is known to increase risk of cancer occurrence. And so again, after a cancer has been treated, and in that survivorship method, bariatric surgery should be considered for patients that are otherwise indicated for or qualifying for bariatric surgery. And again, weight reduction is an important component of the cancer survivorship thought process and should be incorporated in those discussions. Interestingly, 60% of patients with a BMI over 30 and endometrial cancer expressed interest in bariatric surgery. Notably, the only significant difference in patients who kind of qualified and for an interest with or without interest in bariatric surgery actually had to correspond it to the type of primary care physician that the patients identified. Patients who had a family medicine focus were actually more likely to be followed than patients with an internal medicine focus or OBGYNs interested. And so patients, again, who were followed by family medicine were more likely to be interested in bariatric surgery after endometrial cancer, as opposed to patients who were followed by either an internal medicine or an OBGYN as a PCP after endometrial cancer, despite the fact that they were all eligible for bariatric surgery. And I think that speaks to the fact that we need to do a better job as a profession in helping our colleagues understand when indications for surgery are, so that we can make sure patients are apprised of all of their possible options available to them. 60% of gynecologic oncologists report being inadequately prepared to provide weight loss counseling. And only 50% of gynecologic oncologists actually reported including weight loss counseling as part of their survivorship plans. Only 10% actually received any more formal training in obesity management, despite endometrial cancer and ovarian cancer being such a large proportion of a gynecologic oncologist practice. Women are more likely to actually accept a bariatric surgery proposal, referral, when it's offered in the course of their endometrial cancer survivorship. And so this is a particularly key part in a patient's recovery, when not only are they at a good location to be referred for further education and for weight loss counseling, but when it is an ideal time to intervene to reduce the risk of developing cancer recurrence in the future for them. And when we look at the effect of bariatric surgery on cancer mechanism, again, we looked at both inflammation, insulin resistance, and hyperlipidemia, as well as health system utilization that can drive the obesity and cancer risk for this patient population. Specifically as it pertains to increased risk of inflammation, we know that bariatric surgery decreases systemic inflammation. It has actually been shown to reverse telomere shortening in patients following bariatric surgery. And there's an increased level of circulating adiponectin, as we discussed, following bariatric surgery, with adiponectin being that more protective kind of adipokine compared to the leptin, which is the one we don't like. As it pertains to insulin resistance, as we discussed, bariatric surgery is excellent in improving insulin sensitivity with both improvement and resolution in type 2 diabetes following bariatric surgery. 68 to 76% of patients with dyslipidemia is cured after bariatric surgery, and 94% of patients have a reduction in fasting hypertriglyceridemia 12 years, up to 12 years after gastric bypass, signifying that the dyslipidemia and the lipid metabolism that we know can help, that is one of the mechanisms that drives cancer development and progression, is something that can be reversed following gastric bypass. And as it pertains to health system utilization, participation in a gastric bypass program often improves health system engagement. Following up with a bariatric program is actually mandated as part of both your entry into and following bariatric surgery, which can improve adherence to routine screening. And engagement with a bariatric surgery program can alleviate healthcare worker bias that patients may, that otherwise may prevent patients from adequately seeking care and feeling comfortable within the healthcare environment. In terms of next steps, I think it's very important that we continue looking further deeply into the oncologic benefits of bariatric surgery, teasing apart which mechanisms are really altered in the kind of oncogenic milieu in patients with and without a history of bariatric surgery to better understand those molecular mechanisms. It's also important to evaluate whether the oncologic risk reduction is actually behavioral versus molecular, and that is one of the focuses of the PCORNET study that I'm a site PI for, to help understand if some of the benefit we see is just because of that increased engagement in the healthcare system and undergoing routine surveillance that leads to early diagnosis. It's also important to continue our education of patients and providers on the oncologic risks of obesity so that we can understand and emphasize the importance of early both medical, behavioral, and surgical intervention to combat obesity. And furthermore, just food for thought, it's important to note that there is a significant increase in childhood obesity, that quadrupling of adolescent obesity over the course of the last 40 or 50 years portends an increase in adulthood obesity and associated cancer risks that cannot be ignored. And do we need to consider adjusting our screening recommendations for adolescents and young adults with obesity in order to either catch these cancers earlier or intervene earlier in order to, again, kind of bend the curve on the risk of cancer for these populations? So kind of wrapping up a little bit before final questions, I'd love to get your thoughts on whether you would consider, knowing the information that you have learned today, whether you would consider referring eligible patients to bariatric surgery, or kind of counseling patients in whatever practice you have, and if so, when would you consider? Would never, if I have not swayed you at all, or before cancer diagnosis, at the time, anytime, or at the time of a diagnosis and or after completion of cancer treatment. I'm just curious to kind of see where people's thoughts are. Okay. Awesome. I appreciate it. I think lots of kind of thought-provoking. I like the switching. I'm curious to hear people's comments in just a minute. Okay, I'd like to thank everybody for your attention today, and I'd like to thank the teams that I get the opportunity to work with. Dr. Tim Farrell and Dr. Wayne Overby are my bariatric surgery partners here at UNC, as well as up at Hillsborough. Lisa Prestia is our phenomenal rock star bariatric nurse coordinator who gets it all done. Tara Zeikowitz and Tasha Rosser are our nurse practitioner and PA who help with kind of pre-op and post-op education and patient follow-up. I'm privileged to be part of the Division of GI Surgery here, which is a really just wonderful group of folks dedicated to expertise in kind of upper and lower GI surgery across the board, both cancer and non-cancer. Our fellow this year is Madeline Higgins, that we've been very lucky to work with and continue to train for the next couple months before she goes on to the real world. And then, of course, my team at home puts up with a lot of time away and a lot of time with my patients, and very proud of them and thankful for them as well. Thank you for everybody's time, and I'm more than happy to take any questions. Resources are here as well. I guess we can kind of click.
Yeah,
Tim, you can take over. Sorry,
we're going to go back
yeah.
one. Oops, there we go. Okay, so Dr. Hodges, this has been fascinating. There's a lot of things to think about here. I'll get a question out of the way because I'm sure you get asked this a lot. Semaglutides, and what's the relationship? Where would they have a role that might help a patient not require bariatric surgery? Where would they not be appropriate? Is there an interplay between the two where both can be beneficial? Would you address that, please?
No, thank you so much for the question. I know it's a very common question we get in clinic and otherwise. They are fascinating and can be wildly successful medications for folks. More and more over the last 10 years, we have recognized that obesity is truly a systemic disease, and a large proportion of it appears to be development of a higher kind of central set point for the body. And so patients are capable of losing 10, 15, sometimes 20% of their excess body weight with some of these medications. That is, of course, patient dependent. Some people just don't seem to respond as well. The data is suggesting more and more that those medications need to be continued anywhere from 18 months to 2 years or longer. And I will be the first person to say that I think Dr. Cobiello, who's the director of our obesity medicine program here, probably has more information to suggest and would be a great speaker specifically to that point. But not a lot of patients can afford to be on those medications for 18 months or 2 years. Some people have adverse effects that they can't tolerate. And so I think they're great medications for some. I think some people can receive the benefit of long-term durable weight loss and lifestyle change in order to reset that central set point for themselves. But I think that there are a lot of kind of financial and societal barriers that keep that being possible for many patients. I think that it's actually very exciting, kind of the partnerships between obesity medicine and bariatric surgery that are developing in many places. There's almost a neoadjuvant approach where patients receive behavioral and medical weight loss options if they're not kind of making the progress or getting to where they want to be, or if we know that they're starting off with a BMI in the 50s, 60s, 70s, and may not and will not ever be able to achieve a normal BMI in all likelihood without the addition of surgical weight loss. Then we're able to kind of, I think, mobilize all of our resources and get everybody working in a coordinated fashion and kind of a neoadjuvant approach with medications and behavioral and then surgery, and potentially even an adjuvant approach should patients still continue to benefit from the medications postoperatively.
Gotcha. Thank you so much. And I should have said these are medications like Ozempic and Wegovy, and of course recent changes in state insurance are going to make those even less available for many patients.
Yeah.
Let's see, we've got one. We've got them coming in, and just a reminder: if you're in the audience and would like to share questions, you can do that through Poll Everywhere now. Thank you for the informative presentation. How do you see GLP-1s affecting obesity, cancer care, and bariatric surgery in coming years?
I think a great question again, and I think we've touched on that a little bit. I think the impact of GLP-1s on cancer is something I'm honestly not super familiar with. I think many folks are more willing to consider a medication concurrently with a cancer therapy than perhaps an invasive surgery, especially when you're considering a surgery that may have an increased risk of adverse events if combined with radiation therapy or systemic chemotherapy, which can often affect wound healing and postoperative courses. And so I think if, again, not knowing much data on how GLPs influence cancer progression and cancer outcome, it would not be outside of the realm of kind of consideration to use those when bariatric surgery might not be considered safe.
All right, thank you so much. Here's another one. If you elect to delay cancer therapy for bariatric surgery in an indolent cancer, how soon post-op can you safely perform the cancer-directed surgery? What markers should we use to time that surgery?
I think that's a great question. So generally speaking, the majority of the weight loss is lost in the first 9 to 12 months following bariatric surgery. So in that time frame, patients are a higher risk of developing almost a protein-calorie malnutrition because of the rapid weight loss. And so typically, if possible with the cancer course and other treatments required, I tend to recommend getting at least 9 to 12 months out of their bariatric surgery. Patients can lose significant amounts of weight up to 18 months to 2 years, but the majority of that weight loss is in that first year. And the weight loss thereafter is relatively kind of slow and steady thereafter. So generally, if you can get to the 9 to 12 month course following bariatric surgery without changes in the cancer progression that would kind of maybe indicate need for earlier intervention, I think that would be ideal to make sure that nutrition and is optimized for the cancer surgery.
Great, thank you.
And just to be
So
clear, there's no literature for any of this. This is to be clear, this is just gonna my bias and my own concerns and what my thoughts would be on that regard.
Understood. Thank you for qualifying that. So many good questions coming in. We're not going to get to all of them, but here's another. I noticed the reference to diet and exercise for DM control and in the post-cancer DX journey, but is there any diet exercise course requirement before bariatric surgery, particularly for those who are capable of doing so, no joint injury, et cetera? Just curious, your thoughts on the potential quick fix lens side of things for bariatric surgery, not without risk, versus truly dedicated effort to first try and lose the weight with diet and exercise.
I think it is the rare patient who hasn't really tried diet and exercise, and long-term sustainable weight loss with diet and exercise is typically, it is rarely going to result in more than about a 5% sustained weight loss. And so when you're looking at the impact that that patients are really needing, either from a metabolic standpoint or a cancer standpoint, or a true kind of lifestyle standpoint, that's just, it's something that the majority of patients are, no matter how hard they try, are kind of fighting their genetics and their metabolism and quite frankly our built environment that kind of complicates their ability to be successful at the level that's needed to really impact a lasting change for them. For bariatric surgery, many pairs require 4 to 6 months of supervised weight loss. There have been randomized controlled trials that actually compared patients that were mandated to lose 5 to 10% of their excess body weight prior to surgery versus those who did not have a strict required weight loss. And there was no difference in sustained long-term weight loss between the two. And so most pairs have abandoned that requirement. Although I know most surgeons also like to see some progress, at least in weight maintenance, if not kind of a small degree of weight loss to show that patients are kind of getting and understanding the lifestyle modifications that are necessary to be successful long term. It's certainly kind of we do try and approach it from a holistic approach as best as we can.
Thank you so much. Oh, one last question, and then we'll go ahead and do closing remarks. And you mentioned bias within the healthcare field. Can you talk just a little more? We don't have much time, but how that impacts patients, sort of the ways in which that can interfere?
Yeah, absolutely. So again, there's a very strong relationship between BMI and incidence of mood disorders. And so in addition to patients who may have high rates of depression, there's also the social stigma that comes with obesity. And so patients feeling shame asking for help with their weight, patients who may be made to feel shamed by family, friends, and unfortunately even by healthcare providers at times. We also know that obesity, of course, comes with the risks of obesity-related comorbidities, and so unfortunately, with the demands that our health system places on primary care physicians, it is hard to address all of the health effects that need to be kind of managed and taken care of in the time available. And so sometimes even though from a public health perspective, the best thing might be helping to address the weight and ultimately affect all these end results. Oftentimes the limited time available leads to the necessity of addressing the medical conditions that are the most urgent at the given moment. So I think a combination of all those things.
Thank you so much. Well, I think we could go on talking for about 20 minutes. I know I've got at least that many questions, and there are others I apologize we didn't get to, but we do need to go ahead and wrap up. We want to say thank you to the state of North Carolina, to the UNC Lineberger Comprehensive Cancer Center. Within the Cancer Network, we have a team of folks working hard to make every one of these lectures happen. That's Venny O'Burray, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh. So thank you to all of them. They all play a role in making sure these happen.